give you the lay of the land when it comes to digital health. We have a very special moderator that did me the honor of participating, Dan Munro, a contributing editor to that tiny little publication called Forbes. His commitment to writing about digital health is unparalleled, and we're lucky to have him. I'm going to let you take it from here.
Thank you very much. And it's great to be here. I hope there's some readers of the articles. The key part to that is editor, in the sense that I'm encouraged to have an opinion, and I'm not afraid to share it. So I may not always get an upvote in the sense of the Facebook style, but in any event, we're trying to be the healthcare compass and always pointing north. So the panel here is absolutely phenomenal. We've had a bit of a change in lineup, and as it turns out, it's because two of the panelists actually had to avail themselves, continuing to avail themselves of our healthcare system. And I've already offered one of them to help write about that from the vantage point of being the CMO, Chief Medical Officer at AARP. And we'll get an update from Jody Holtzman, who's here to my immediate left, who's Senior Vice President of Thought Leadership at AARP. And each of the panelists will get a chance to sort of introduce themselves, because I think that's key. And then we'll start to dive into some of the key questions. And then towards the end, we'll open it up and make it available to general audience questions. Next to the left is our remaining female participant. We went from a ratio of 3 women and 1 man to a complete change in lineup, but Amanda Goltz is with Pacific Business Group on Health, and a significant nonprofit coalition of some really, really big names in healthcare. And so at the forefront of seeing some of the activity that's really important to all of us. And then to her left is Nick Martin, who's Senior Vice President of Innovation and R&D at United Health Group. United obviously needs no introductions in the sense of being at the sort of the top of the pyramid relative to being the largest payer. 77 million covered lives is staggering, and not just here in the U.S., but as we were talking about a little bit beforehand, is also representing 17 or 18 other countries. So truly a global footprint, but one of the statistics that doesn't come out a lot is 99,000 employees. So we can get a chance to talk about that relative to what, how healthcare works for 99,000 employees as well. And then last but certainly not least is a personal, sort of a personal connection that I wanted to highlight is Bill Spooner, who's Senior Vice President and CIO at Sharp Healthcare here locally. And we have a direct connection there that Bill isn't aware of, but I wanted to share with you, is that our son, who just turned 10, was actually born at Mary Burge. And we're big fans, and Sharp is doing some amazing things. So in terms of thought leadership and in terms of being at the forefront on the provider side, it's a real pleasure and an honor to be on a panel with Bill. Because Sharp itself is a Malcolm Baldrige Award winner for 2007, and that award is only given out, I think, every 5 years. So they'll probably reapply in 2012, and I wouldn't be surprised if they, they win it again. And then Bill personally was voted CIO of the Year by HIMSS. So those are sort of some of the early credentials, but we absolutely want to give them a chance to introduce themselves, and also to focus in as tightly as they can on what they're seeing relative to these vantage points in the digital healthcare spectrum. Jody?
Well, hello. My name used to be Charlotte. I'm sitting in for my friend and colleague, Charlotte Yeh, who's the Chief Medical Officer of AARP Services, which is the for-profit subsidiary of AARP through which our commercial deals are done. She she's had I'm going to speak for her, and I don't think she'll mind. But Charlotte actually, since coming to AARP, has had an incredible transformation in how she views the healthcare system. And you know, she's an ER doc. She worked at CMS. I mean, just an incredibly accomplished person in the medical world. And then comes to us and starts to really around the time that consumer-centric, patient-centric healthcare really started to become a buzz and started to get attention. And she really started to rethink the whole paradigm. And then in early December, 6 months ago, it was a rainy night near our offices in DC, and she was hit by a car. And luckily, there was no structural damage, but just incredible soft tissue trauma. And she's still recovering. She's just been off a walker about a month ago. My colleague Jeff and I saw her up at Health 2.0, and she's getting around on a cane. But she wasn't given the okay to sit on a plane for as much as 6 hours, both directions. But what's fascinating, and this is what Dan was getting to, is that now she's had the opportunity to now like perceive the healthcare system once again, but this time from the perspective of the patient. And it's really fascinating. And we were talking about it last night, and she gets in, and she's left like on a gurney, like almost all night in a hallway, and then starts communicating who she is, what she does, etc. And all of a sudden she starts getting better care. Well, that's not the average person who can actually do that. Anybody can do that, but nobody will have the beef behind the claim. And so she's been okay, but she really did start to get this different perspective. So I run a group called Thought Leadership, and you see these two big signs here, and thanks Jill for getting those done. And one of our jobs is to put a spotlight on the 50+ market, on the needs and wants of the 50+. So this is actually a question that we have a campaign around, and we're trying to get VCs in particular to add this question to their list of diligence questions, so that it becomes the flapping wings of the butterfly that starts the tsunami of innovation focused on the 50+. And so far, so good. But it's only when you start to actually ask the question that you start to think about this humongous market of patients in this case, but consumers as well. 100 million people and growing, $3.5 trillion annual consumer spend. And then you have segments. So you got boomers like me, and you still have my parents, and I'm sure some of you youngins, your grandparents. But I just want to make a couple points. One, I think this whole issue is one about orientation and not about technology. And I think it really goes back to a lot of the same issues that have confronted technology-based products and services in the consumer space and everywhere else. That we get so enamored of the gizmos, and particularly when it's the engineers and the founders of those companies who are excited and should be by what it could do. Who cares? Does it catch mice? Does it help me? And one of my catchphrases these days is that in Washington, 100 million people is called an unaffordable cost and burden. In the entrepreneurial community, 100 million people is called a market and an opportunity. But it's only a market and an opportunity if you really think about, marketing 101. Start where your customers are. And in this case, in this realm, digital health, it's where your patients are. It's where the individual is. And you have to think about, one of the things I liked about the previous presentation was the orientation to be holistic. And I think that that's really, really key. And we know that, you know, it's only when you treat the whole person that the health outcomes are really improved. So particularly for older people, the fact that if people are isolated, that's as much a driver of poor health outcomes eventually, you know, as is a, you know, a flip in blood pressure, right? So how do you ensure that it's not just remote monitoring of spikes in this or that, but it's also connected living, and that you have access to human beings, and it's high touch and high tech? You have to start thinking about starting with the person. So as Charlotte says, it's not just about adding years to life, but it's about adding life to years. And I think that that's, you know, the paradigm I think I just want to leave with.
Absolutely.
Hello, everybody. I am mic'd. That's very exciting. My name is Amanda Goltz. I'm here from Pacific Business Group on Health, which is an employer coalition based in San Francisco. And our members are large self-insured employers. I really want to thank Jill and the other organizers of the conference for asking the employers to be here today, so I can speak for them universally. Because I think that as a stakeholder, the employers are left out of this digital health conversation. Partly, honestly, that's because they've been slow to adopt innovation, but it's also because their role in the healthcare ecosystem is not well understood. And I want to give a big dissertation on that, but if I could sum it up in one factoid, I would say that Starbucks, which is not a PBGH member, but is a large self-insured employer, spends more on healthcare costs for their employees every year than they do on coffee beans. So is Starbucks a coffee company or a healthcare company? I'm still not sure. What PBGH does is, on behalf of our 60 member companies who collectively spend $12 billion annually keeping their employees healthy, or rather addressing their illness, we work on projects to lower the cost of care, improve quality and access, and help employers understand the value that they're getting from that healthcare. My job inside of that is I have some ridiculous title about being manager of the digital health portfolio, but honestly, when it comes down to our members, which are Chevron, Boeing, Walmart, Wells Fargo, Union Bank, Target, and Safeway, among others, it really translates into the internet. What is it, and can it help us? So I ask for all of your patience in understanding that the employers are very anxious to understand digital health, understand what their employees are doing to keep themselves healthy, understand how they're interacting with their health plans, the health system, and all of the devices that are penetrating their lives and collecting their health information. But the employers are just at the very beginning of trying to understand this and understand what their role in it is, rather than just shelling out dollars. How can they intermediate for their employees and get involved in the conversation? So we're just starting to sort of embark in this world, but we're very anxious to see what we can do to help all of the bright minds that are already active in it.
Perfect. So as Dan mentioned, I'm Nick Martin. I'm part of United Health Group, and I have the pleasure of being part of an organization that focuses in innovation specifically, that crosses both of our books of business, our United Healthcare Benefits book of business that many of you know of from your insurance cards, but also focusing on how we might impact innovation to the consumers through our services side of businesses that manages the products and services that are served up to members through our nurses and others. I'm looking forward to the conversation I hope that we have here as part of the panel, because my passion in this space is really about shifting from looking for health care and getting a consumer to care about health, which really transposes into how do you engage the consumer? What are the triggers that get someone to move to caring about the health that they get, and not that they've come down with a condition or a chronic disease, but how do we get them to care early on about health care? So I'm really looking forward to the group of panelists here and the conversation.
Good morning. I'm Bill Spooner. Is my mic on? Yes, I'm Bill Spooner. I'm the CIO at Sharp Healthcare. I've been with Sharp for longer than I can remember, but I've been CIO for the last 16 years. As was mentioned, we were very proud to be, the recipient of the Malcolm Baldrige Award 5 years ago. But that's really part of a longer journey that we've been on that's really around improving experience. We call it to be the best healthcare system in the universe, and we sort of have to chuckle when we say that, but it really provides this motivation for the whole team and to rally around. And we started this in about 2000 or 2001 to be the best place to work, the best place to receive care, and the best place to practice medicine. And it's been kind of interesting to see how it has evolved over the years and is continuing to. Most of my job is supposed to be boring. In other words, the systems are supposed to work well and do what they're intended to do all the time. Now, it gets interesting because that doesn't always happen. You know, in San Diego, it's just a fantastic dynamic community with the technology base that we have here, with Qualcomm stimulating the growth of various wireless ideas. And you know, they recently introduced sort of X-Quarter Prize, and we have the West Wireless Institute, where two very generous philanthropists have put up over $100 million to find ways to promote better health care through various wireless technologies. We have some incubator organizations, the UCSD, University of San Diego, California San Diego Connect program incubates many different technologies, including healthcare. Some specific organizations. I joked to our board a couple of months ago at a meeting that every time my boss goes to a cocktail party, I look at another product. And it is kind of interesting because you know some of these things are going to be really fantastic, and some of them are going to be, I'll say, flops. And it's kind of interesting because we go through these, and while I may find something that I think is really wonderful, sexy, I'll say, then I put it in front of the physicians and they say, well, this doesn't really help me change care. So I think we're going through this trial and error thing about what's going to work best for the patient. You know, we've exposed, for our Sharp-Resteenley Medical Group, we've exposed some of their information through a portal. You can't see this, but this is the mobile version of MySharp. We have about 75,000 patients on the full portal, and we rolled out MySharp a week ago, and we have about 700 people who've already downloaded it from the Apple Store. So this is really a beginning to get the patients exposed to their information. But you know, there's a lot of interesting things you want to go through to make sure that you're not exposing things that might be controversial test results before the doctors had a chance to explain them to them. Nothing worse than make them think they've got some dreadful disease and it's not really the case, and then they wonder why they didn't hear from their doctor sooner. So there's a lot of dialogues. The one thing that we have been pretty rigorous about in terms of getting our patient involved is that when we started the portal project over 2 years ago, we started with focus groups and brought patients in and asked them what they'd like to see, how they would interact with it. And so we got a lot of feedback like that. We're about to go in the next step to decide where we want to go on the hospital side in terms of some of the functions for hospitalized patients. And we're right back to the focus groups because we need to hear from our patients. This is, you get into this debate about whether I'm doing this to make life easier for the physician, the nurse, and other clinician, or whether it's really about the patient. And that's kind of the sort of the deliberation that you go through. Thankfully, we have a pretty healthy perspective of it. We have some board members who recognize that, and and there is the patient attention. Another thing that we're doing here in San Diego locally is that we were one of the communities that got a Beacon grant for creation of a health information exchange. And we've been going through this forming and storming thing. It's kind of hard to get all of these competing providers to really come together, but we're in the process of forming the initial board. It's, oh yes, we need a consumer representative on this board. We got to have the patient represented in this. And I think it's just kind of an evolution that we're going to go through. What we see in 5 years is kind of hard to tell. I'm sure the patient will be more fully engaged. A real disappointment, I will say, is some of the direction that we've received from the feds. This thing that's called an accountable care organization has very little accountability on the part of the patient. They don't have to go to one provider. They don't have to change their healthcare practice, and the provider has to keep them well. And I think we've got to find ways to stimulate well-being among the patient community if we're going to really improve healthcare.
So as a result of the last, I think probably 7 or 10 days anyway, there's been a number of either individual press releases, and if not, then Bill, just forgive me, and maybe you can chime in with something that's relevant along those lines. But I know that AARP just announced a partnership tie-up, if you will, with Microsoft on the Health Vault, and so help us understand what that sort of entails, because obviously a personal health record, in the sense of a historic perspective, has had some real challenges. So obviously that's changing, or help us understand what you see with that.
Well, I'll share what I know. You know, I think it's it is part of a recognition that people do have to simply manage their own healthcare, right? The system's not doing it for people. And this is simply one tool that will be among many that will enable that. You know, I think that, you know, going forward, the future of EHRs, PHRs is that they're going to be completely passive, you know, and, you know, so for example, if my father was responsible for populating his own, forget it, you know, first you get the drugs wrong, then you get the dosages wrong, you know, and who knows what he would be fed. But, you know, for us, it's an evolving relationship with Microsoft that's part of a larger thing. We've done some work with them about online safety, some research recently about boomers in technology. So it's a larger piece of a Microsoft AARP relationship. But I think but the bottom line is that, you know, our message to our members and to the 50 plus in general and to society is you have to step up, and here's a tool to help you do that. And we've also, you know, internally to staff, we've, you know, made it available earlier on.
Great. And, you know, John Moore from Chilmark Research made the reference, maybe not initially or even the first, but are we headed towards what is considered or could be considered a collaborative health record, CHR, as opposed to either an EHR or a PHR? In a sense, that's part of what, you know, I think we may be gravitating, and maybe this is a first step towards that.
Yeah. Well, you know, I think the entire system, you know, is going to have to be, you know, collaborative. I think when you start, you know, talking about older people, though, particularly 75, 80 plus, then it's a different story, right? So only about a third of them are online to begin with. Even a smaller number have smartphones, and you have smartphones, as you know, so I don't know about any of you, but I think there's a reason why, you know, iPads came along and you saw the uptake much more significantly amongst people over 50 than with iPhones, right? The icons are bigger. Your finger can actually touch one instead of two. Why Apple? I mean, you know, I bow to the brilliance of Apple and Steve Jobs, but you know, why is it that you can't just like expand the icons, you know, even on the iPhone to make it bigger, the way you can with, you know, with text? So I think that for our populations, there's a lot of things that have to happen, and there's going to be as much offline as there is online, and the collaboration part of it is going to be that, as opposed to, or in addition to, the collaborations of the various stakeholders. And the other part of it is the caregivers, right? So the caregivers somehow have to, you know, have an easy way to play a role in all of this. And just on that point, this was something that was a little bit of an epiphany a while back. You know, there are several folks in the audience who are entrepreneurs in the area of aging in place technology. And, you know, almost all of the players in that space are direct to institution, right? They're B2B. Nobody has cracked the nut, which is the really humongous need and opportunity of direct to consumer. Nobody's figured out how do you get it into the house on scale that, you know, really addresses the scale of the need. And but part of it is that there's actually two sales that have to happen, right? So there's one sale probably to the caregiver. So for me, I'll put 1 million sensors from my perspective in my parents' house because I'm concerned about them falling, I'm concerned about their safety. For me, it's a peace of mind value proposition. For them, if I go to my parents, particularly Harriet Holtzman, my mother, you know, and it's like, Mom, we got it. We can keep track of you 24/7. My mother's a working class woman from the Bronx. I won't tell you what 2 fingers on each hand would be raised and the words that would come out of her mouth directed at me. It would be, get that out of my house. What are you, and part of it is, what are you saying about me? It's the psychological suggestion that she's infirm, that she's incapable, right? Which is, nobody wants to hear that at any age, but our society is always telling people, you're frail, you're this, you're that, rather than, Mom, what are the things that you want to do? This is going to enable your freedom. This is going to maximize your independence. This is going to, so there's 2 value propositions, there's 2 transactions. One may be, you know, commercial, but the other is no less a transaction. She has to allow it into her house, and I think that's true of any of the technologies that, as a patient, as a consumer, that she would have to interface with.
So there is this huge shift, and we're talking about it. I've offered the original panel the idea of offering up two topics that was sort of top of mind from each perspective, and the unifying theme from everybody was consumer engagement. And so that's clearly a major theme, and a big one that seems to be even emerging within that as a category is the entire notion of pricing transparency. And we have 2 sort of opportunities to talk about that relative to both what you're doing, Amanda, and then also what United Healthcare is doing. But Amanda, you did something recently here that I really want to dive into, because it was a secret shopper that you now have published on your website. So tell us about that, and tell us what you know, what the results were that you found with that.
Sure. So first, I'm going to apologize to Nick. I pretended to be somebody else and went on the United website. Our members, despite the fact that they pay for the healthcare claims of their employees out of pocket, they of course use the health plans as valued partners, not only to provide a physician network and administer claims, but to provide tons of programs that engage the employees in health. And among them are the services available on the health plan's website for employees to be able to access information about their benefits. Recently, there's been a huge developmental curve in the development of cost estimators. So I, as a member of United or Aetna or Cigna, can go online and say, I am contemplating getting care for this condition. How much is it going to cost me? And as everybody in this room knows, that's an enormously complex calculation. What are my benefits? Am I going in network or out of network? What are my out-of-pockets? Where am I in my deductible phase, my co-insurance phase? All of this complexity that goes on that can vary actually specifically not just by health plan, but product, PPO versus HMO, or by employer. So our members were very curious as to what that experience at the employee level looks like. And I offered to secret shop all of the health plan's cost calculators, run a series of 9 imaginary patients through them. You know, I'm on these cardiac medications, the cost is killing me. How do I get it down? I haven't been to the doctor in a while. What do I need? I have low back pain. That's it. I just have low back pain. Tell me what I should do. And I did this literally by asking my friends which health plan they had and could I log in as them. And I developed a series of analyses with screenshots that we delivered to our members and said, here's how your plan stacks up. The general dimensions that we took a look at were the out-of-pocket estimates specific to the members' benefits, or was it just a series of regional price averages? Did it track where I was and if I could use my FSA dollars to help defray the cost, for example? Then into the more complex sort of interactivity of the tools. Did it give me cost comparisons among settings and among providers? So is it very clear if I have a sore throat that's going to be much more expensive for me to seek care in the emergency room as opposed to going to an urgent care clinic or maybe calling the nurse line? and then across different treatment alternatives. And there was only one plan who did this sort of in a very engaging, transparent manner, so that if the standard was, with most plans, you type in back pain, the autofill or the only match to the search term back is actually MRI. So instantly we've come back with the most expensive intervention when most back pain resolves itself within 6 weeks without intervention. But there was one plan that said, oh, you have back pain. You could get an MRI and it'll cost you this much, or you could get an X-ray and it'll cost you this much. You could go get physical therapy, chiropractor visit, it'll cost you this much. Or you could see if it resolves in 6 weeks, and if it doesn't, we'll ping you back and we'll say, do you still have this problem? And that plan was United. So there's a huge variation, and I think that members are starting to do this more of plans. Employees are starting to do this more. Really care about the costs that are going to come out of their pocket. I know that our employers are shifting the cost to employees in huge numbers. High deductible health plans have become a standard offering in all the employers. Several of our members are going what we call full replacement, so that a high deductible health plan is the only option you have for your coverage. And we think that this will stimulate more interest in engagement, at least at the cost level, because the employee now has skin in the game. And the burden is on us to make these cost estimator tools accurate, timely, easy to use, and informative. And if that's our engagement point with the employees, well, that opens up a whole new world to tell them tons of stuff about how they can take care of their health, right? And engage with their benefits. So the last step for that internal project was we sent letters to the health plan saying, here's what we liked, here's what we didn't like. Could you fix the deficiencies and tell us why? But I really want to hone in on that aspect of this sort of dawning realization on the employee, boy, I better see how much it's going to cost me and what my alternatives are. Once that channel is open, what can we do with it?
I'm just really curious. Are the employers concerned at all that instead of making smart choices, people make bad choices? So high deductible, I don't want to hit that, I'm out of pocket up until whatever. I'm not going to go to the doctor. I'm not going to get the prescription filled. You know, and then you end up in the ER because whatever it is escalates, and or you don't, you know, get on your regimen, and it also escalates. I mean, any concerns about that? I think that there's a very superficial perspective when it comes to behavior mod. And that if you just throw money at it, people are going to behave. And I think that people will behave and will respond very short term and not think about this from a larger, you know, longer term perspective and from a strategic perspective. Are they concerned about this?
Yeah, they're hugely concerned. And I think that hesitation, that concern has been what's held them back from high deductible health plans up to this point. Now it's become a back-breaking cost question. I mean, you simply can't go to your CFO and say, I need another 25% increase in my budget for healthcare costs this year. And you know, at some point, your fiduciary responsibility to your shareholders says you got to do something. So the cost pressures are unbearable. I think the ways they're trying to work on that is an incredible communications and access effort around prevention. So worksite clinics really focus on bringing you the preventive care, free, where you work, where you are, so that you don't say, you know, I don't have $200 to go to the doctor, I'm just going to wait till I go to the ED. There's a huge effort to have worksite wellness, to sponsor activities where people walk during lunch, healthy food in the lunchroom. Shift managers and team leaders are responsible for the health of people on their team, and they're supposed to sort of uplift both people's motivation to take care of themselves and keep an eye out for when their fellow employees are struggling with a health condition and maybe not seeking care. I'm not saying any of these are a magic bullet or that they even fix the high deductible health plan model if there is some avoidance of necessary care there, but they're attentive to it, and I think the employers do understand that they have the employees' attention for 8 hours a day at least. What can they do?
Jody, I think another aspect of that is, and first of all, before I move on, Amanda, I didn't put you up to that.
No, I did. That's very. There were things I would like to fix on the United website, but that was good.
That can connect you with our PR people later if you'd like to. But I think that, you know, as you pointed out, Dan, that, you know, we did just release an upgraded mHealthcare cost estimator tool for consumers in our plans to get that level of detail, Amanda, that you so eloquently pointed out, so that I don't have to do that. But Jody, you know, I don't think it's a replacement necessarily for the conversation that needs to happen with the physician as well. In fact, you know, later this year we'll be expanding on our mobile applications to enable that same kind of capability in the hands of the consumer and the technology that's, you know, connected to their belt loop, so they can have that same back pain conversation with their physician at the point of care, and really talk about those alternative care paths.
We're going to do that with our Medicare products?
I'm very sensitive and want to serve your Medicare patients and products.
For those that don't know, the AARP Medicare products, Medicare Supplemental, Medicare Advantage, and Part D are branded AARP through United Healthcare.
Indeed they are, and we will certainly continue to offer tools and technologies to that book of business as much as we can.
I think that one of the huge challenges around pricing transparency is really understanding what a complex industry we are, and how differences across practices may affect it. I would say that if one hospital is more expensive in everything they do than another hospital, is probably a valid comparison. But you always get into these conversations about, well, my patients are sicker than your patients. And, you know, and that may really be true, and we respond differently to medication. So I can't necessarily say that when I go in with some grave illness that it's going to cost the same to treat as it will the next person. I ought to be able to say that if I have my knee replaced, it probably is something that should be able to be quoted to me reliably. But we start about the complexity of the human condition, and then we start looking at the individual types of institutions. We take care of the indigent patients who can't afford to pay. And realistically, if I have twice as many indigent patients as my neighbor, I'm going to pass those costs along to somebody. So that affects the rates. So I guess if you wanted to get the least expensive care, you'd always go to the community that has the least indigent care. And then we get into just the nature of the industry itself, that we're such a cottage industry, as opposed to some countries that have all single payer. We have, you know, dozens of payers. A few years ago, I looked at our list of hospital pricing profiles, and we had 600 different payment schemes just for hospital side.
Yeah, there's about 400 payers listed nationally, but the breakout is really high relative to those. I think the ratio is about 30 that have 1 million lives or more, and there's like a whole, you know, 370 that are 250,000 lives or less. So there's a huge breakout there.
And because this is a competitive world, each one payer tries to create a unique package that they can market differently than their competitor. And so, you know, this impacts what the patient sees.
Yeah.
I think as I hear more and more people say, gee, maybe it would just be better if we had single payer. And then on the provider side, we're going through this culture change we say reduce variation, because standardization is a dirty word. But great physicians go through medical school and they're trained finally, and they learn to think for themselves and to be unique. And then we get them into the new world of hospitals, where we say, okay, and we want best practice. We want all you guys to do this procedure, doing it the same way, and pick the same brand of products, basically raw materials, because we know that overall it works best, and we can also drive the best deal for them. And there's a lot of resistance to that. Maybe 20 years from now we'll have accomplished it across the country. There are some systems that are well ahead in this game. I have to say, unfortunately, we're still struggling with it. We're better than we were 5 years ago, but it's, you know, a lot of this area of variation, and as we're able to drive that out, will be more predictable.
Bill, your organization is ranked very high, and in fact has been ranked, I think, for the last 9 years as one of the 100 most wired hospitals in the country for every year that they've been tracking this. Have you taken that to the point of, are you deployed iPad-wise throughout the hospitals, or how are you seeing that relative to deployment?
Let me clarify the most wired. We were on the list the first 11 years, and then we fell off the list for 2 years. I think we may get back there this year.
Okay.
And I can tell you why we fell off, because
Okay.
we're behind as far as medication barcoding.
Oh, okay.
We sort of think that that's a gimmick. It's really, it's not the pills that are dangerous, it's the IVs, and we spent our focus on IV improvement. And we're only recently rolling out really advanced disaster recovery capabilities. And with those two things, I think we'll be back on the list. But in terms of mobile devices, we're seeing some adoption, and we're encouraging it, but it's not, I don't believe the numbers that I'm seeing published. I saw a report yesterday that 30% of physicians are using it in their practice. I bet they're checking the stock ticker.
Yeah.
I mean,
Yeah.
And our two EMR products, one of them works very well with the iPad, and there's a little bit of usage, but it's just not highly.
Yeah.
The vendor recently introduced an iPad-specific product that would be a lot easier to use, and the physician said, well, you know, I don't think it's there yet. I'm not in a hurry. I expected they'd be beating down my doors to bring it in. Now, we're seeing it in some cases. Another product outside of the iPad, I brought in an HP Slate for a couple of physicians, and that, with another one of our products, that worked really well for them, and they use it all the time. So, but we're seeing some usage, but not a lot.
Not
I know it's
dramatic,
going to happen. I was at a meeting, my primary, I don't want to do a commercial for Cerner, but you know, they're coming out with a number of iPad-specific screens, and I think that they're going to catch on.
Yeah.
And internally, because I have to do the boring job of making sure that it all works, we're looking, and when we're about to do a deal with a company that helps you to better manage personally owned devices, so that we can let them run their hospital applications without interfering with their others, and we put some security controls on them.
Bring your own device is a key element of that, and that's huge. And I think it also bridges a lot of that, that space between the business tension of convenience versus security. And we're seeing that sort of as a hybrid between both the consumer side and consumer applications that are web-based. I don't know if anybody saw the article on Fitbit. I mean, it's a great product. How many people here have, sort of a Fitbit? They got into a bit of a trouble last year with some of the data that was available online through Google. So we're still at the very early stages of testing that sort of tension in the business world. But back to this original notion of the high deductible plan, because I really do think there's an element there, and we probably don't have enough time to get to it today, but there's an element there that I do think is concerned. First of all, the average cost of healthcare today for the family of four is for the first time, according to the Milliman Index, over $20,000 a year. So the consumer is feeling the pain in the sense of the wallet. Now the employer is coming back with high deductible as the preferred mechanism for keeping cost control. Isn't that placing additional risk in the sense of the kind of preventative care that we need to have in place for avoiding the high-cost specialty care down the road? In other words, you're putting the consumer into the position of saying, okay, I may need this preventative maintenance care for $1,500 using a cost comparator or a cost estimator. I may need this procedure or this test or this preventative program for $1,500. Meanwhile, Best Buy is over there offering up, the 80-inch LCD panel for $14.99. Is that the kind of risk that we want to be engaging?
Is it just that a choice?
It could be, and it may be coming soon, and it may be coming soon to your health plan. Is that the kind of risk that you're seeing?
Should I take this one?
Absolutely.
Everybody be looking at you.
I know, seriously. It's rare that the employers are the villain, but here we go. I definitely think that I hear a lot of people talk about we need a free market for healthcare and we need this. Nobody wants healthcare. Just like the TV example, nobody said, boy, I can't wait to pick a doctor and go get my annual physical. No one says that. So, you know, whether it's free or costs $50 or costs $500, you're still already dealing with a resistance factor where people, you know, don't want to, they're frightened of what they might be told, they don't want to be nagged to lose weight and exercise more, or, you know, they don't want to take the time out of their day, or they can't take the time out of their day. So I think that price is a factor, but there are many angles of resistance that people have to overcome when they interact with the healthcare system for their health. Now, Lord only knows what's going to happen this month with the Affordable Care Act, right? But there are provisions there that most preventive care is without cost. And the health plans have been great in making that clear and not in adjusting all the back-end data infrastructure billing so that that is actually true and not with cost. The amazing thing about healthcare, though, is that it's a balloon. You squeeze one end and another side blows up over here. So now what we're seeing is a diagnostic test, you know, the stuff that the American Task Force on Prevention says are things you need, colonoscopies at 50, mammograms at 55. And when something is found on those diagnostic scans, that immediately becomes a chargeable event, something that you can now collect for if you're a provider, or charge your health plan or charge your employer. So prevention is free, except when it's not. I think the way employers are trying to deal with, because you know they're hit twice. If an employee doesn't seek the care they need, not only does it cost them money because they're paying the claim, they're paying the cost of the absenteeism of that employee. It doesn't do an employer any good to have an unhealthy workforce. In fact, it's incredibly costly and a very bad way to do business. So I think, you know, back to what can the employer do with the 8 hours a day that they have their employee with them? How do they encourage them to take care of themselves through mobile apps, through reinforced messaging, through worksite clinics? How do they monitor the health of their employees without being too big brother? How do they provide actual financial incentives for people to take care of themselves? So they, you know, a lot of our member companies who have gone full replacement with a high deductible health plan fully fund the HRA or the HSA and say, we're giving you the same money we would have anyway to cover your deductible. Just we want you to use it. We want it goes away if you don't use it. Or they during open enrollment every year, they take a series of biometrics, weight, smoking test or usage of tobacco test, blood pressure, blood sugar, and then they measure you a year later. If you've had improvement in those biomarkers, then you get an additional $5,000 in your HSA. So they're playing around with the psychology of how to engage people in prevention, which is something people are inherently resistant to do, but the employers recognize their responsibility. There's just got to be a better way than flat out subsidizing the first however many dollars.
I don't have any numbers to support this, but we saw as high deductible plans came into place, higher bad debt, which ends up being passed on to someone. We know that people, you know, delay elective work when they have to put up their $5,000 themselves. I think it's for an informed consumer, for elective medical procedures. It's a great thing. Let them shop. But you know, when you're being dragged into the emergency room, you don't really get a lot of choice of what you're going to get, and you still have to come up with the $5,000. We've also heard these unfortunate stories where hospitals are being, I mean, the thing in Minnesota, for example, where you know, hospitals are being beaten up because they're aggressively pursuing the deductibles because they're afraid that they're not going to get them if they don't collect them up front. And so that's, you know, really getting in the way of giving good care. I'm not sure that, you know, just inflating the deductible is really helping the consumer, helping anyone. And it's a nice idea, but we need to test that more.
Nick, are you seeing results with this relative to the consumer side?
Well, Amanda pointed something out that I think is really important, and the trend around incentives and really encouraging people to know their numbers. But before you know, traumatic events happen, we've seen a tremendous uptick in identifying conditions for individuals that could become, you know, very costly to the individual from a price as well as a well-being perspective. So these plans that have incentives around people taking biometrics at the beginning of the year, we oftentimes find individuals who are pre-diabetic or diabetic that didn't know they were, and able to help coach them through those programs and to really keep their costs down and lower. That's absolutely a trend that we're seeing.
I think that because it's a competitive world, neither an employer nor the health plans are ready to be the first one to charge a risk-adjusted premium. If I smoke here, I'm going to pay a higher premium for my insurance. That would certainly impact me. If I'm overweight, I'm going to pay a higher premium. Nobody wants to be the first one because all the business is going to go away for a short period of time.
That actually does happen with smoking today.
But yet, until there's something, until the consumer has a piece of the action, I'm not confident we're going to get there. I mean, we just started this year rolling out what we call Sharp Best Health, and it's really incentives. Exercise program. I just got my pedometer this morning. I don't know how many steps I've walked so far, but I'll certainly have it on tomorrow. I'm running on the elliptical, so that I get credit for it. But it's all on the incentive side. We're not ready to penalize me for my bad habits yet.
What's interesting about the whole panel is that we haven't spent a lot of time talking about the Supreme Court decision, and I think that sort of speaks volumes in and of itself relative to, yes, it's important, and yes, we do have the legislative side of healthcare, but we also have the innovative side, and those are really the two bullets that we have. We have about 5 minutes left, and I wanted to open it up. I could ask questions all day, because that's sort of the nature of what I'm geared to do, but I wanted to definitely open it up for any questions at all from the audience that wanted to dive in. Anybody at all? There's one. Get a mic.
One of the big challenges, not only am I involved in digital healthcare, but I'm on the board of a federally qualified health center. And what we see happening is we have all these great insurance plans and whatever, but at the end of the day, if somebody can't afford insurance, they make too much money, they make too little money, they're on Medicaid. And there's not a lot of initiatives that we see that are addressing this population. And those are the folks that completely fall through the cracks. Do you see any innovations that are going to be brought into the market for this population?
Well, I can take that one.
Yeah.
Just a real quick one off the cuff would be a pilot we're running in a few states called Baby Blocks for the Medicaid book of business, which really encourages expecting mothers to engage in the pregnancy care and to understand what to expect along the way with their care. The Medicaid book of business, ironically, as it might seem, is a higher utilizer of mobile technology than a lot of our books of business, believe it or not. We get over 70% of our calls from that Medicaid book of business from mobile technology today. And in fact, it's oftentimes the only connection to the outside world that those individuals have. So we're piloting really a program where our Medicaid individuals can have a mobile phone, can have reminders around their care, and can incentivize them through discounted products and services for their newborn as well.
Just to build on that, first of all, the data show that mobile phones and particularly smartphones have higher penetration in particularly Latino and African American communities, and that is the primary or a growing source of online connection. CMS, Medicaid in particular, and it's similar to what Nick was talking about, has a pilot with Text for Baby, for example, which also is kind of just text reminders about getting your prenatal care, getting your baby checked, for whatever those monthly checkups are, and stuff like that. And I know in the Medicaid office, 'cause I just know people there, they're very much on top of this. There's also been just stuff. I think that to Nick's point about, to Dan's point about the Supreme Court, it's less about. I think the Supreme Court, what they do is going to be incredibly important. That said, there's just a lot of trains that have left the station, and people are focusing on access, on cost, and quality, and the marketplace is going to be experimenting, and I think that's the period that we're in now. It's a period of experimentation, and I think once we start to see the cost curves and the outcomes, you see the better outcomes, which long-term lower costs. You're going to start to see my friend Nick here paying for most of those things if the government isn't. So, but the experiments have to prove true, and we'll see. But there's a lot of work in Medicaid.
As I commented at the beginning, there's just a tremendous amount of innovation going on.
Yeah.
And some of it's going to work. We don't know which one it is. I kind of worry about the innovation at the federal level because there's this idea that you could just try something and then put it across the country tomorrow. And that is going to create a lot of errors. But we're going to find some of these clever ideas come out of startup companies that we'll find, gee, this really does bend the cost curve. This really gives better care at a lower cost. And then people will adopt it because it absolutely makes sense. So we're seeing all this innovation, and we're seeing a tremendous amount of venture capital going to it. And I think that's healthy. So you have to be optimistic about the future.
And to that point is that there are two bullets in the gun, legislation and innovation. I don't speak to the legislative side because there's coverage across the board. I mean, we have to watch and monitor it, but I'm absolutely a big fan of innovation. Were there any other questions? Yeah, yeah.
This is for Amanda. You mentioned in your opening remarks that the employer has been left out of the kind of digital health, employee health picture. Two questions. First of all, are you sure they want to get involved? And then second of all, if they do get involved with the digital health and the employee relationship, have you seen some good models where it's worked and everybody, all the stakeholders seem to be participating and engaged and it's valuable?
Yeah, both great questions. To the first, I certainly hope that the employers want to get involved, because if they don't, I'm out of a job. But I also have a personal passion for it, and I think that it's time that the employers woke up and sort of understood the world as it is, at least in terms of what their own employees are doing in their off time and during their work time in monitoring their own health and engaging in these communities online. I think, you know, the critical thing for employers is prove me the ROI. Show me how this is going to save me money. I don't care where it comes from. I don't care whether it comes from, you know, more well-rested, healthier, feeling good employees doing a better job every day, or whether it comes from a decrease in costs, or whether it comes from a decrease in the disproportionate share that gets put on me because I'm subsidizing others' care because our system's a little out of whack right now. I don't care. But, you know, show me how I'm going to save money. And I think that becomes a little bit difficult to prove in this experimental and rapidly evolving world. A model that I've seen works well is to get away a little bit from the traditional channels that we've seen delivery come from. No disrespect to the gentleman on my left, but you know, I'm not sure that the health plans, which have been doing a great job of large data management, claims administration, provider networks, and the hospitals, which have been giving acute care, you know, are meeting the employee in their daily life, those observations of daily living. Gosh, I really want a cigarette right now because the bus is late. I need help this second. You know, a hospital and a health plan can't help at that moment. But sure, a bunch of peers online that are accessible through your smartphone that will cheer you and distract you and prevent you from having that cigarette, they really can. So I think employers are starting to move away from their traditional partners and try to think about who they can work with. Cost models really matter here. Traditionally, employers have paid for things on a per employee, per member basis. We're starting to see some pricing models that are based on engagement. So the burden is now on the third-party vendor or the company or the innovator to engage the employees, and that's when the employer pays. Or on actual outcomes. Those biomarkers measured at a year-over-year system that I spoke about earlier. You know, pounds lost per employee actually has a dollar value to employers. So I think really trying to drive through who needs to be at the table to deploy an innovative new project to keep employees healthy. Are they sharing data among them the way they should? How are we measuring and evaluating? And what's the cost and ROI model for the employer? If you have those figured out, I think you're head and shoulders above the rest.
I wish we could continue this conversation. And you can later. You can find everyone here. I want to thank you all for participating.